Hello, everyone. I'm Dr. Niranjan Chavan from Mumbai. I send greetings to Endoworld Conference, Aurangabad. I am unable to come because of some administrative issues in my college, and hence I am sending this recording for the benefit of all the delegates who have come. At the outset, I would like to thank Dr. Pandit Palaskar and his team to invite me for this wonderful conference. And my topic today is adnexal masses in pregnancy, and I'll share my experiences with you. So today is 14 December 2025, and we are in Aurangabad. I will be talking on management of adnexal masses in pregnancy. I would like to quote here by Ken Poirot. Today is your opportunity to build a tomorrow you want. And I'll be sharing the experiences of last 15 years of adnexal masses in pregnancy. The first case which I got was in 2010, which I'll be describing in the later part of my lecture. But before that, we need to understand what is adnexa. So basically, adnexa is derived from the Latin word adnecture, and it is encompassing the fallopian tube, the ovary, and the vessels and the ligaments and the connective tissue. Now, it's very important that during pregnancy, we have serum, AFP, beta HCG, and inhibin, which are all raised and they are synthesized by the placenta. And these are very important markers when we are evaluating any adnexal masses, primarily for the ovarian cyst. Now, CA125 is elevated not only in pregnancy, but in another conditions also. But during pregnancy, due to the decidual cell production, the level rises and it progresses. And the cutoff which is suggested in pregnancy is 112 units per ml as compared to the normal 35 units per ml in the non-pregnant state. So this usefulness of the tumor markers, however, is restricted. And if you have an ovarian mass or an adnexal mass to be suspicious, then we need further evaluation to be done by an MRI test in pregnancy. Now, if you see the overall incidence of adnexal masses, it ranges from 2 to 10%, and rarely you can find malignancy during pregnancy. I had a discussion with Dr. Tongaonkar. He's an expert on ovarian tumors, and I asked him whether he has seen any cases of adnexal masses in pregnancy. He said, Niranjan, in my 25 years of practice, I have only seen 3 cases. So it is very rare, and the incidence is 0.04 to 0.4%. In some cases, the ovarian pathologies which we come across are detected in cesarean section. And I had one case where this ovarian big watermelon size mass was undetected even in serial ultrasounds, and it was directly detected on the OT table when the baby was delivered, and when they were cleaning the paracolic gutters, the ovarian cyst had totally taken the form of the paracolic gutters like a watermelon, and it was detected in cesarean section. This was published in a journal, and also it had got a lot of media coverage in 2014-15. Now, in view of the advent of ultrasound, which is done in early pregnancy, the detection of adnexal masses and ovarian masses are much more higher as compared to 2 decades earlier. So I'll come back to the case report which I encountered in 2010. This was a case referred from Rajawadi Hospital. It is a peripheral hospital which is there about 6 kilometers away from Sion Hospital. She was a 25-year-old fourth gravida with three living children, and she had come with 4 months of amenorrhea with pain in the abdomen and abdominal distension. When I examined her in the OPD, she had a 28 to 30 weeks soft cystic mass which was non-tender mobile, and on further PV examination we found that the uterus was palpable about 14-16 week size, and there was a mass which was felt separate from this uterus. So we did an ultrasound and further MRI evaluation, and it turned out, which you can see here in the picture, nicely shown, that there is a pregnancy in the center of the pelvis, just above the pelvis, and on the left hand side, you find an ovarian mass with one septate there. So this was further evaluated with tumor markers, and all the tumor markers were normal. And this was a case in 2010. So we did took a consent, explained the relatives. The first thing which comes in the mind of the patient, कि मेरा बच्चा गिरा दो. But that doesn't solve the problem. So we had to literally explain her and her husband that we need to operate. And I did the first laparoscopic ovarian cystectomy in Mumbai, probably the first that time in this part of India, Western Maharashtra. And we did by the open Hassan's technique, and we did supraumbilical. You can see the port there, and we went ahead and did a laparoscopic ovarian cystectomy. And we also aspirated 300 cc of serous fluid. This was a cystadenoma. Since it was a benign, it was a successful surgery. The patient withstood the surgery, and post-operatively she went home. And later on, Aisha came with the baby to show me after 1.5 years. It also had a lot of publicity in news and media, and I had a harrowing time explaining. So that was just a candle in darkness, light, which I focused there, and I got so many patients after that because of the publicity which I got. And I got many patients not only from Maharashtra, but people started calling me from Uttar Pradesh, from Bihar, and they started taking appointments. So I thought I should give this, to one of my student, and we did a lot of research on this and gave it to subsequent students also. Now this case which I operated in 2010 got published in Bombay Hospital Journal in 2014. So you can imagine how much time in those days it used to take to just publish a case. And Rupali Gaikwad was that time my student. Now she's a lecturer in one of the Maharashtra Government Medical College. And Chinmay Pataki is now practicing in Dombivli. Mahesh Chand Shetty has gone back now, and he is doing very well in Karnataka. And Aarti Ade is a consultant IVF working with Dr. Indira Hinduja. So this is what you feel good when your students excel and prosper in their career in the future. And I'm really happy that all of our names got published in the Bombay Hospital Journal, but it took 3.5 years. Now we go to the next case. This was a 26-year-old. She came with 6 weeks of pregnancy, antenatal. We did an examination per abdomen. It was absolutely soft, but there was a mass which was palpable on PV examination in the right fornix, and this uterus was felt separate from this mass. We did an ultrasound. It was 4 to 4.5 centimeter in size. We further did an evaluation. The fetus was fine, 6 weeks pregnancy, heterogeneous mass, and it was diagnosed as a mature cystic teratoma. There was no other pathology. The left ovary was normal. So we explained this to the patient. Now, since the size of the cyst was less than 5 centimeter, the safest approach would have been conservative management. But as soon as you tell a tumor to the patient tells, नहीं नहीं वो निकाल दो आप. So you have to explain them the risk of the surgery which you do in the first trimester and the anesthetic gases which can affect the pregnancy in the first trimester. So you need to understand also that this patient can undergo torsion, and we have to have whether she has any symptoms of pain, vomiting, etc. So with all this explanation given to the patient, the best approach to such cases if they are absolutely asymptomatic, is to attack this ovarian tumor in the second trimester and do a cystectomy, but not an oophorectomy, and avoid the spillage because that can cause chemical peritonitis. So I would like to share with you now this wonderful video which I have for a dermoid. So once you have hold this with a crocodile grasper, you can just shave off, cut the cyst wall and enucleate the mass. While doing so, you can do counter traction and traction, and with the help of the grasper on both the sides, and here we have cut the cyst wall. We have gradually made a space and separated it from the cyst wall. This can also be done with a suction cannula and going around over a period of time. You can see that how you can separate this ovarian cyst. Remember, do not open it because if you open, it will cause spillage. You can see another ovarian cyst also being there, which was missed on the ultrasound. You need to do only ovarian cystectomy and not remove the ovary because that will hamper the progress of the pregnancy later. And a proper removal of the whole cyst wall is to be done. And the base has then to be coagulated, cauterized, so that the hemostasis is achieved. And this ovarian cyst in toto is then removed in the bag along with the cyst wall. And there is no peritoneal spillage. That is what you have to be importantly knowing. That's what we did. Unfortunately, this got ruptured, but luckily it was not that much very thick viscid material, and we could absolutely salvage this patient. And further, we went ahead and conserved the patient, and she delivered later on. This is the third case which I would like to show. 26-year-old primary gravida. She had come with 20 weeks period of gestation. She had abdominal pain for about 2 weeks, but there were no symptoms of any torsion. On examination, we found that there was pregnancy which was 20 weeks in the center, and for abdomen we could find a soft cystic mobile mass which was felt in the flanks. This was mobile and the mass was palpable in the right fornix. On PV examination, uterus was felt separate from this mass. We further did an ultrasound and it confirmed the diagnosis that this was a unilocular 6 into 5 centimeter thin walled anechoic cystic lesion, and that was confirmed, and it was located there in the right side and it was away from the ovary. So this was a para-ovarian cyst which we came across. Well, if it is less than 5 centimeter, you can leave it alone. But since it was more than 5 centimeter and there was a probability that it can be causing torsion, we had to operate her with a proper consent and we removed this. And this is what video I would like to show you now. Laparoscopic ovarian cystectomy. Now here you find that absolutely the cyst is there. We open the cyst wall and totally make it away from the ovarian mass. Here also we try to see that the hemostasis is achieved, the bleeders are coagulated and cauterized. As they are magnified here into 10x, we have to be little careful also, not to worry about it. And that's what we did in this case. And you can see that with a proper grasper hold on one side and totally enucleating it away, we could get this whole cyst wall, para ovarian cyst, away, and then we could remove it out in a bag, endo bag, and safely take it out. Now, fourth case I would like to discuss with you. This was a 30-year-old married for 1 year, and she had complaints of amenorrhea and with abdominal pain and PV spotting bleeding. You can see that the pregnancy test is positive here with two lines. Beta HCG was high and she had come with normal blood pressure. Pulse was 78 per minute, no pallor. On examination, everything was fine except there was a tenderness in the abdominal, lower abdomen. And on PV, gentle PV, we found that there is a right adnexal fullness and there was a right formational tenderness. Cervical movements were tender, and we could find that yes, this looked like a suspected ectopic pregnancy with minimal spotting being there. A transvaginal sonography was done. There was no intrauterine gestational sac. There was, however, a ring of fire appearance on color Doppler. And in the fallopian tube, right side, there was a gestational sac about 5 to 3 centimeter noted, and echogenic pulsations were there. There was no free fluid in the pouch or Douglas. This was an unruptured ectopic pregnancy, and we could further take a proper consent and go ahead by doing a surgery on this patient. So here you can see there is hemoperitoneum in the pouch or Douglas, and the right fallopian tube shows there is an ectopic pregnancy. Now, ideally, you can just cut the antimesenteric border and pluck out the pregnancy out. This is one option which is helpful to be much more conservative. The other option, if she has completed a childbearing age, you can do a partial salpingectomy with a proper consent, achieving hemostasis, and we can go ahead and do a proper salpingectomy. And then this specimen is to be parked anteriorly and removed out from the endobag through the second accessory port. Here also you can use directly and suck it out to the second puncture. You can see the other ovary, there is a cyst which is there. We did not do anything. We sucked out the hemoperitoneum which was there in the pouch or Douglas, and this is how an unruptured ectopic pregnancy was managed. So basically, once you have confirmed that there is an adnexal mass, you need to understand that since the pregnancy has to be continued, tocolysis have to be given, glucocorticoids should be given when she is nearing term, and proper management of threatened preterm delivery has to be done because these patients can undergo abortion or they can go in preterm labor. Use of monoelectrocautery is to be avoided in such cases, and because that can cause uterine contractility. Fetal heart assessment has to be done preoperatively as well as postoperatively, and later on, for any further problems, you need to have also fetal monitoring done. Now, you have to maintain the CO2 gas not more than 12 to 15, because if you exceed that, the patient can go in maternal acidosis and there could be fetal acidosis also. So that will cause the further, reduction in the placental blood flow and fetal oxygenation. So this care has to be taken by the anesthetist from their point of view. We need to understand. Well, complications, as you are aware, can come across while doing a surgery. Laparoscopy is not a risk-free procedure. It is associated also with low weight to the birth and IGR, risk of abortions, risk of preterm labor, and there could be anesthetic complication. Torsion could be there in adnexal mass, an infection, rupture, and fetal malpresentation and obstruction of labor. So after all the studies which we did over a period of time, 3 years, we did a study which got published in the Clinical and Experimental Obstetric and Gynecological Journal. And here 42 cases were studied, and I will go through that one by one. But the most common one we found was dermoid and cystadenomas, not a single case of malignancy in this 3 year period. And adnexal masses are quite common. So if you see the age-wise distribution from 26 to 30 years of age, we found them to be quite common. It was more common and seen in multigravidas rather than primigravidas. And if you see the gestational age, the maximum number of cases which we found were in the second trimester. Of course, we did an ultrasound also to confirm the diagnosis and MRI in cases. And most of the cases which we operated were in the second trimester, as it is the safest period where we can go and operate. Now, 40% of cases we found that the adnexal masses were between 6 to 10 centimeters, and this is comparable with other studies also. which is about 8 centimeters, and the levels of CA125 were about 11 to 25 in our cases, and 6 cases had torsion, 2 had hemorrhage, but there was no rupture, infection, and malignancy. It is quite comparable with other authors in the same age group and in the same criteria category. And electively, we managed 24 cases. Emergency, we had to do in 8 cases, while 11 of them were managed conservatively. Now, the histopathology, you see that commonly what we found that buccinous cystadenoma were found in 29 and teratomas also in 29 cases, while the others were serous cystadenomas and simple follicular cyst. But there was no malignancy reported, and this is quite comparable with Hess et al., Agarwal et al., and Ballard et al., which have been doing the studies. The perinatal outcome is very interesting, and I'll tell you that after doing a laparoscopic surgery, you do not need a cesarean section. 52% of them delivered vaginally at term, and in preterm, we had about 5% of cases. 2 cases that had an abortion, but it is expected to have in such cases. So the take home message I would like to give all of you that most of the cases you find are benign and most of them are functional cysts, but they are quite common with dermoid and cystadenomas. Ultrasound is the first line of investigation along with an MRI can be helpful, and of course tumor markers is also importantly done, especially CA125 alpha fetoprotein and beta HCG of course will be higher. Now you have to understand that if they are asymptomatic and if it is less than 5 centimeter, we just leave them alone. But if they are more than 5 centimeter, there are chances of symptoms and it is a complex or a suspicious mass. We are more worried that they can undergo a torsion. They need to have a multidisciplinary approach. Go ahead and do a laparoscopy, but preferably electively and in second trimester. Unless it is an emergency, then maybe you will have to also go in the first or the third trimester. Laparoscopy is a preferred method. You have to see that the best is that the CO2 is maintained in 12 or to 15, but not more than that because you need to avoid the fetal acidosis. And always send the mass for histopathology. Continue tocolysis post-operatively. Show that documentary evidence of an ultrasound, fetal heart sounds, if they are persistent post-operatively, so that you are not a cause of the fetal demise or an abortion and you do not land up in medico-legal issues. With this, I would like to end my talk with a quote. It always seems impossible until it is done. And today, the whole world is doing laparoscopic surgeries in pregnancy. And if I can do, you also can do. And I'm sure it is going to be a wonderful conference with all of you being there with Endoworld in Aurangabad. Thank you for a patient listening. And once again, I thank the members and the delegates of this conference, and especially Dr. Pandit Palaskar and the Aurangabad Obstetric Gynec Society to make this conference a grand success. I miss you all, but I'm sure I will catch up with you soon in AICOG Delhi and meet all of my friends there. Thank you so much. See you soon. Bye.